Neurotube defects are caused by an incomplete closure of the neurotube. It can occur anywhere along the spine, but incomplete closure of the caudal region is the most common area. Anencephaly is malformation of the anterior end of the neurotube. When all the neurofolds fuses, it creates a tube with an opening at each end. There's a rostral end and a caudal end. Failure of the rostral neuropore to close on day 28 will cause partial absence of the brain in the calvarium. The forebrain will not develop, and the baby is not viable. Spina bifida neurotube defects. There are three: myelomeningeocele, meningeocele, and spina bifida occulta. Spina bifida in general is caused by the neurotube not closing properly, specifically the neurofolds not coming together. It can occur anywhere along the spine. Vertebral structures do not form over the area where the neurotube do not close. This often results in damage to the spinal cord and or nerves and may cause physical and or intellectual disabilities. Meningeocele is a fluid-filled sac containing part of the spinal cord and nerves. It is the most serious type of spina bifida. It involves both the spinal cord and the meninges, and it will be filled with cerebrospinal fluid. This can cause moderate to severe disabilities. Meningeocele spina bifida is the next level. It is a fluid-filled sac that protrudes through the opening in the baby's spine, again where the neurofolds did not fuse. It does not contain the cord, but it does contain cerebrospinal fluid and can cause minor disabilities. Occulta is the mildest form of spina bifida. There will be a small gap at the posterior aspect of the vertebral arch that did not completely fuse. It is often asymptomatic and does not cause any disabilities. It also will often present with a tuft of hair over the defective area. Syringomyelia is the development of a fluid-filled cyst called a sphinx within the spinal cord. The cyst is filled with cerebrospinal fluid, and it can also block cerebrospinal fluid. It is most common in the cervical region, and the sphinx that are in the cervical region will affect the brachial plexus and its nerve roots. Cysts may enlarge, and if they do, they can damage the cord. They'll impede cerebrospinal fluid, which will also increase intracranial pressure, causing pain and headaches. What causes syringomyelia? There's a number of things that can cause it. A very common cause is a congenital defect called Arnold-Chiari malformation. It can also be caused by trauma, tumors, or infection. Arnold-Chiari malformation is a condition in which the brain tissue extends into the spinal canal. It can be asymptomatic. Symptoms are often triggered by some unrelated event, such as a motor vehicle accident. The complications that are caused by Arnold-Chiari malformation can be hydrocephalus, spina bifida, a tethered cord spine syndrome, or syringomyelia, and that's why it's covered in this lecture here. There are three types of Arnold-Chiari malformation. Arnold-Chiari type 1 is the most common and mildest form of Arnold-Chiari malformation. It develops as the skull and the brain are growing. The cerebellar tonsils will extend into the foramen magnum. That is specifically described as a herniation of the cerebellar tonsils, the medulla, and the fourth ventricle into the spinal cord. Arnold-Chiari type 2 is observed on ultrasound in utero. It is often caused by a small posterior fossa. A greater amount of the brain tissue, the cerebellar tonsils, will extend through the foramen magnum. And this type of Arnold-Chiari type 2 is often associated with myelomeningeocele spina bifida. Arnold-Chiari malformation type 3 is also observed via ultrasound in utero. It is the most severe type of Arnold-Chiari malformation. The cerebellum and the brainstem protrude right into the foramen magnum and can cause severe disabilities. Syringomyelia due to trauma. Spinal cord trauma, such as that caused by a car accident or a serious fall, can cause a syringomyelia or a cyst to develop, but it may not show up until years later after the injury. Syringomyelia due to tumor. Tumors can occlude the central canal, and this occlusion can cause a shrinks. The shrinks will cause syringomyelia. In this example, you can see that there is a shrinks developed above and below where the tumor is located. Syringomyelia due to infection. This is an image of a 22-year-old male with tuberculosis meningitis. Meningitis is caused by inflammation of the meninges around the spinal cord. You can see in the MRI, the inflamed area, there's at least 2 shrinks developments within the spinal cord where the tuberculosis has caused the inflammation. Syringomyelia signs and symptoms. If the shrinks is in the cervical region, which we said is the most common area, there will be isolated loss of pain and temperature sensation across the shoulders and upper extremities. The patient will experience a cape-like or shawl-like distribution where they do not feel pain and or temperature in an area that's usually covered by a cape, and that's how it got its name. What's happening is the anterior spinal commissure fibers are being compressed upon, and so the signals can't get through, affecting the transmission of the spinothalamic tract. Syringomyelia early signs and symptoms are headaches and migraines, neck pain, head pain, pressure in the head and neck, dizziness, lightheadedness, tingling, numbness in the extremities, fatigue, muscle weakness, and low back pain. All of these symptoms are very typical symptoms that a chiropractic patient might exhibit when coming to your office. That is none of the reasons why we cover some of these conditions, because you just don't know what your patient might have. Now we're moving on to cerebral palsy. Well, what is it? It's a non-progressive neurological deficit. It affects a person's ability to move, it affects their posture, and their balance. Affected persons may have related intellectual disabilities, seizures, problems with vision, hearing, their teeth, or speech, and it's often associated with scoliosis and joint contractures. Cerebral palsy results from prenatal or perinatal CNS damage. Often affects the caudate nucleus, putamen, and thalamus. There go, you understand why they have movement disorders. Most cases, though, are due to brain damage prior to birth. The CDC statistics say that this is the most common motor disability in childhood. The prevalence is high. Around the world, it ranges from 1.5 to more than 4 per 1,000 live births. The CDC estimates that 1 in 323 children in the United States has been identified with cerebral palsy. The life expectancy, depending on the severity of the condition, can be a normal lifespan or only to the age of 30. It also depends on the degree of damage that was done. What can cause cerebral palsy? Any event that damages brain tissue in the pre- and perinatal periods. Probable causes are cerebral anoxia. This diagram demonstrates cerebral anoxia with the cord being wrapped around the baby's neck, cutting off oxygen. Hemorrhage can also cause it, hemorrhage from either trauma or a incompatible Rh factor. Stroke can have it. A baby can have the stroke, or a mother can have the stroke and cause the baby to lose circulation. CNS infections can cause it, and encephalopathy. There's just a multitude of conditions that can cause brain damage to the infant in this time period. But the most common ones are anoxia or hemorrhage. There are 4 types of cerebral palsy: spastic, athetoid, aka dyskinetic, ataxic, and mixed. Spastic cerebral palsy is the most common type of cerebral palsy. Affects 50 to 80% of all cerebral palsy patients. It primarily affects the motor cortex, causing severe increase in muscle tone, leading to dystonia, and will manifest with a hyperreflexive deep tendon reflex. There's 3 types. Spastic diplegia will present with a spastic diplegic gait or scissor walk. Spastic hemiplegia will present with a hemiplegic gait. And then spastic quadriplegia, the patient is not ambulatory and typically cannot walk. Athetoid or dyskinetic cerebral palsy affects about 20% of CP patients. It primarily affects the basal ganglia, manifesting by slow, writhing, involuntary movements known as athetosis, which is how it gets its name. However, there can be intermittent episodes of involuntary movements that are rapid and jerky. Involuntary movements will impair voluntary movements. This usually affects the arms more severely than the legs, and these children are typically non-ambulatory. Athetoid and dyskinetic continue. It'll affect involuntary facial movements, making speech difficult. Athetoid movements become more severe with stress and decrease with relaxation and disappear completely with sleep. Muscle tone can change from too tight to too loose from day to day or even several times during a single day. Ataxic cerebral palsy only affects 5 to 10% of cerebral palsy patients. It results from damage to the cerebellum or its pathways. The patient will manifest with hypotonia, abnormally low muscle tone, and they'll present with hyporeflexia, significantly decreased deep tendon reflexes. There will be a lack of leg movement, especially during infancy. They'll present with a wide-based gait as the child begins to walk. Ataxia will make sudden or fine movements almost impossible, and these children will typically resort to a wheelchair just for steadiness, not that they cannot walk. Mixed cerebral palsy affects about 20% of CP patients as well. The most common combination of mixed cerebral palsy is a combination of spastic and athetoid. These children have significantly impaired motor function, and growth and development are extremely delayed. They'll develop dysphagia, where they have difficulty eating because they can't swallow. They'll have dysarthria. Almost 80% will have impaired speech if they can speak at all. Almost 40% will present with significant intellectual impairment, and 25% of these children will have seizure disorders. Early diagnosis of CP can be a bit difficult, but it is essential for effective treatment. From birth to 5, a child should reach certain movement goals called milestones for each stage, such as rolling over, sitting up, standing, walking, etc. A delay in reaching these milestones could be a sign of cerebral palsy. On this slide here, I have the link to the CDC, where they have a list of milestones for each stage in each child's life, so that you can compare it with your patient's child if you are suspecting cerebral palsy. One can suspect cerebral palsy in an infant for some other things that really aren't movement related as far as reaching a milestone, and one is such as difficulty suckling or keeping the nipple or food in their mouth. This is not like failure to thrive syndrome where the child doesn't want to eat. These children are hungry and are trying to eat. They just can't keep the nipple or the bottle in their mouth. Another sign is that they seldom move voluntarily or has arm and leg tremors when they do try to move. Another sign would be crossing the legs when lifted from behind rather than pulling them up in a bicycle pattern, which is a normal position for an infant being lifted in that manner. Another sign you could suspect in an infant is that the legs are difficult to separate, making changing their diaper difficult. They frequently will hold their legs straight out with them crossed at the ankles. Another one is persistently using one hand to grab or reach for things, and it's beyond just showing a side of dominance. They won't use the other side or the other hand at all. Or as they get older, they'll use their hands, but they won't be able to use their legs very well. Diagnosing cerebral palsy is not easy prior to the age of 2 if it's mild, because the child may be reaching some milestones. However, if you do suspect cerebral palsy, an MRI or a CAT scan will be performed, and you would be able to see some of the gliosis on those images. If you also suspect it, you'll do some lab tests to rule out differential diagnoses such as genetic disorders, metabolic diseases, and neurodegenerative diseases.